I'm just really going to talk a little bit about using what you've already got and, reusing, recycling, which is a great buzzword at the moment. And I think blood conservation is a lot about recycling and reusing what you've got, and that's very important part of the whole process. And I think you've got to approach blood conservation from the very beginning. You've got to pre-op, intra-op and post-op. And I know Gavin's doing a lot of work on transfusion triggers, and at Papworth we're doing a lot of work on pre-operative anemia. And this is really the intraoperative side that I'm going to talk about today. And it comes down to the song that Sam Nashev at Papworth always sings, that every blood cell is bad for you. Every unit of blood that you give increases your risk exponentially. Allogeneic blood is bad for you. You either believe that or you don't, but there's lots of studies now to suggest that every unit increases your mortality exponentially. So a 4-unit transfusion of allogeneic blood increases your mortality by 10%. Whereas there's no evidence that autologous, our own blood, is not good for us. There's no papers, as far as I'm aware, that show that autologous blood is anything except good for you. Are you aware of anything to show that? So allogeneic blood is bad for you. Our own blood, recycled, autologous blood, is good for us. So there's a few ways that we can recycle our blood. And first of all, I'm going to talk about cell salvage. What is the evidence out there? It's been around for 30, 35 years now. Whether we should use it for every case, where we should use it, and some of the tricks of the trade. So cell salvage, the new systems, remove virtually everything from shed blood and pump blood. Most of the systems get rid of nearly all the heparin, maybe about 95%. They all get rid of fat. Most of them get rid of different vasoactive substances, but the best ones get rid of most of them. They all get rid of all the platelets and the platelet clumps. They get rid of all the plasma and most of the white cells. So you're left really with red cells suspended in saline with some heparin and some vasoactive substances, but none of the other things. And that's important to bear in mind when you're trying to work out how much cell salvage you can do before you provide products as well. So what is the evidence? So far, it's now over 310 trials, but when I put this together at the beginning of the year, there were 297 trials over the last 30 years, since the first one that was done with muslin over buckets, with the anaesthetist pouring the blood over the muslin into the bucket and then retransfusing from the bucket. There's conflicting data, outcome measures vary, publication bias, everything that's a problem with every sort of evidence that we look at. So you could assess evidence in any way. Off-pump surgery, 5 small trials, tiny trials if you look at the total number of patients, all demonstrate reduced transfusion. So you give less allogeneic blood by using autologous blood instead. That's logical. It's logical in off-pump that you recycle all the blood that you give back. And now basically it's generally accepted that off-pump surgery, cell salvage, is good for you at reducing transfusion. It doesn't affect outcome, but it reduces transfusion. And if you agree with the premise that transfusion is bad, then it's good for you. So Gavin's trial, 61 patients randomized to cell salvage or none, no antifibrinolytic therapy, no post-op treatment, less than half transfusion rate in the cell salvage group, no difference in bleeding, slightly increased hemoglobin, and no difference in any of the other things. And the key to it is that you have a higher hemoglobin at the end of the surgery and on the ICU. Therefore, you have a modest reduction in bleeding with no adverse effects. There's no statistical difference in overall costs because the increased costs attributed to the cell salvage was saved by the blood. So that's off-pump. On-pump is a little bit more difficult, and perhaps the best sort of systematic review was published 3 years ago now, and it was all published randomized trials looking at all the different outcome measures. And they collected 1,500 odd patients from all the trials. So it's quite a lot of data out there now from a total of 30 odd trials. And cell salvage statistically reduced the use of all blood products and red cells. So this is the number of patients transfused red cells went down from the mid-40s to the late 30s. And the number of patients transfused any blood product from 50 to 43. So that's about a 20% reduction across the board, and pretty statistically significant. There was No statistical difference in any of the other outcome measures that they looked at. So even with 1,500 odd patients, there's no difference in any of these other things, any of the other outcome measures. But transfusion of blood products and red cells specifically are changed in this meta-analysis. So the number of with different data looking at it in a different way, it's still statistically significant. So there's no doubt, looking at 1,500 odd patients, that the number of units of red cells and number of patients exposed to transfusion is reduced from cell salvage, without an increase in FFP or platelets, and no worsening of mortality or morbidity. Unfortunately, no improvement in mortality and morbidity as well. But looking at the number needed to treat and sort of doing a power study myself, you'd need about 20,000 patients to show a difference in outcome. So that's all the meta-analysis so far is 1,500, and it's been repeated at 1,900, still no difference in outcome. There's a long way to get 20,000 patients, so we'll probably never get that many number of patients looking at outcomes. But certainly for just transfusion and red cells, there is a difference. Now, in this meta-analysis, of which most of the data comes from the States, very little from the UK, they have a 51% transfusion rate in the non-cell salvage group, and their average patient gets 1.6 units of red cells per patient. Now, that's probably a bit more than we would say is normal in the UK, where our transfusion rates are probably around 40% on average and are about just under 0.8 units of red cells per patient. So they seem to bleed a bit more in the States. They seem to take a bit longer over their surgery. They seem to stay a bit longer on the ICU, all sorts of differences that we recognise from American trials, but certainly a 51% transfusion rate. So we did a similar trial in the UK where we randomised just bog standard cabbage valve surgery to control or cell salvage. All patients got tranexamic acid, all patients were managed in a sort of straightforward standard way, and we cell salvaged all blood lost in theatre and the first 6 hours in critical care. So the cell saver was wheeled round with the patient to the ICU. All the blood from the chest drains was whizzed through the cell saver and given back to the patient, which is basically what we do. And we got a lot of patients, 200 odd. The two groups were comparable. There was no difference in the baseline data, no difference in the sort of bypass times and the cross-clamp times, no difference in bleeding, no difference in total blood loss. Very few went back to theatre, and no difference in ICU and hospital stay, but you wouldn't expect it in a group of 200. Interestingly, those that were cell salvaged, no difference in those receiving blood products, 32%. Exactly the same in both groups. Exactly the same amounts of FFP, platelets, except the total number of units of platelets were higher in the control group, but it wasn't statistically significant. So routine cell salvage made absolutely no difference, except if you excluded those that bled an absolute load and went back to theatre, where we used a lot less blood in those that didn't go back to theatre. So in other words, those that were bleeding and didn't go back to theatre, where we recycled that blood and gave it back to them, we used much less bank blood. So there was a significant reduction in the volume, number of units of blood used, but not the number of patients exposed to blood products. So therefore you could say those patients that are going to get blood got it anyway, but those that bled got less blood. Now that's very different from the American studies. Now our transfusion rate was much, much lower. It was only 30% instead of 50%. That's the basic trial thing. If you put patients in a trial, everybody's a bit more careful. They don't bleed as much. And you see that again and again. And I'm sure in every single trial you do, it's different. The number of patients that are exposed to the outcome measure is different from what you expect it to be. And the reason is everybody's more careful, perhaps. There's a strict transfusion protocol. The surgeons are more careful. The restenotomy rate was only 2.5% in this study. Our normal restenotomy rate around that time was 8%. It's now about 5%. So why did we have a halving of the restenotomy rate just around the time of the trial? And we used tranexamic acid universally. Interestingly, the cost saving from cell salvage, there was no cost saving. Those differences of about £400 were not statistically significant. That was basically, there's no difference in the cost of using a cell saver. It's a little bit more expensive, but not much. Looking at the number of units on the secondary analysis, you'd need to perform 1,000 cases a year. You'd use 260 units less of blood. So it's not a great saving And you'd need the cost of a unit of blood, which has currently gone down this year to £130 from 150 odd last year. You'd need the cost to more than double to £300 before you'd have a cost saving from using cell salvage on every patient. The problem is that cell salvage is still expensive. The machines are around about £10,000. The kit is between 75 and 150 per patient, depending on what set you use and what sort of discount you manage to get. But on average, it's probably about 100 to 125 quid a patient. And therefore, you need to save, 125 times 2 and a bit. The unit of blood needs to go up to 300 quid before you make a saving. So the managers, when they add up all those results, and this has been calculated from some health economists as well, there isn't yet a saving from doing routine cell salvage at UK prices. But why is there such a big difference between the American meta-analysis and a UK trial? As I said, the transfusion rate is much lower, the number of red cells is much lower, less patients are giving FFP in the UK, less patients are given platelets in the UK, and they're much less bleeding. So are our surgeons better? They bleed less? Probably. They take less time on bypass, so they're quicker. They have shorter cross-clamp times. And this is a big problem whenever you're comparing the US trials, of which there's 8 for every one of ours, and a UK trial. All our data is different. Less patients transfused, quicker bypass times, quicker cross-clamp times. So it's very difficult to compare a UK setup with a UK trial, a meta-analysis based on US studies. And that's where the difficulty is. We look at the US studies, we think, yes, we've got to do that. But you put that in a UK setting with better surgeons, better protocols, but different. And that's what we get. We get very much different set of results. So what should you do now? A lot of centres do routine cell salvage, and obviously that's not a bad thing. That's the ultimate in recycling. You're giving everybody their own blood back. But economically, looking at the UK data, that's not cost effective at the moment. So if you look at it purely from a cost point of view, a target intervention is probably the best compromise between cost and benefit. In other words, if you want to strictly go for money, you target those patients who bleed more than about 1.8 units per patient. So you're looking at, in fact, our redos bleed less than our first-time surgeries because our surgeons seem to be even more careful with the redos. But double procedures, redos, aortics, off pumps, anemic patients who refuse blood, all those patients get salvage at Papworth. So we target those, and that comes to about 800 a year out of our 2,000. However, the other argument is that saving any amount of blood transfusion in any number of patients may be worth it, regardless of the cost. And that would be the argument that a lot of units who do routine cell salvage, like the Brompton or Southampton, would use, that even saving 1 unit of blood in one patient is worth it. But certainly just from a cost point of view, it's difficult to argue that. And then if you're really going to do it on everyone, why don't you do it the whole time? Before you go on bypass, during bypass, after protamine, and do it the first 6 hours in ICU. It's very easy to do it on the ICU. Wheel the cell save around with them, process the blood in the first 6 hours. You can use the circuit for 12 hours, so there's no cost implication. You just got to wheel it around. So you still, for your 125, 150 quid, you do it for the first 6 hours, because sometimes they don't bleed initially, but then they bleed a bit, and you can give them back that blood. And in fact, those ones have the best benefit. So I would suggest that you do wheel it round to the ICU and do it on the ICU. And always have it on standby. If you just set up the cell saver, the collection bottle, that's 25 quid. So you set up the collection bottle, collect the blood, and when you get more than the set amount, wash it. So it's £25 to set up the collection bottle without actually processing it. So if you do that on everybody, that is cost effective. And if you collect 600 mils, not taking into account wash and saline and things you pour in, then you set up the cell save and process. That becomes extremely cost effective. And that will save you tens of thousands of pounds. When we've applied that, we've saved a fortune. So just set up the collection thing and then wash it if you get enough in it. Okay, so I'm just moving on to a few other topics, forgetting about cell salvage for the moment, other ways of recycling. And these are not things that I'm so au fait with, so I had to do a bit of reading about it, because they're not things that we really do in the UK in general. Autologous transfusion, this was trendy in the 80s and early 90s, when patients, especially having orthopaedic surgery, would go to their hospital, give a unit of blood, it would get saved for them when they have surgery. this is pre-operative autologous donation, or PAD if you're American. You give it 2 or 3 weeks pre-operatively, they hold it in the blood bank, and they give it back to you. Unfortunately, you can't put those units of blood in the donor pool. So if you don't have your surgery for any reason, you toss it out. And patients hate the idea of not being able to have their own blood given to them and being wasted. And it is a problem in setting up a service, especially when you have regional services like cardiac surgery, where they'd have to go to their local hospital to get the blood. You transport the blood to your centre, then your surgery gets cancelled because you've got no ICU beds, so you toss the blood. And there's very few systems that have been set up and have worked over a period of time. It has been shown to reduce the risk of blood transfusion significantly overall in a meta-analysis. And this was a Cochrane review back about 10 or 11 years ago. But the methodological quality was poor, and they're actually quite out of date. A lot of the trials were from the early 90s, and because it's not actually done, there are very few trials from the last 10 or 11 years. So basically, it's not done because of mostly issues with collecting and storing the blood. What is done in some centres still is taking off a unit of blood in the anaesthetic room or in theatre whilst you're taking down the mammary, or just before you go on bypass. And in fact, we do that quite a lot with patients who have a very high haemoglobin, sort of 14, 15, 16. We'll take off a couple of units of blood. That blood can be stored at room temperature for 12 hours. You don't need to put it in a fridge. In fact, you shouldn't put it in a fridge. And you store it at room temperature and then give it back to the patient either at the end of bypass or afterwards. That works well and does reduce transfusion. But again, a lot of the trials are quite old. And it's difficult because in cardiac surgery, some of our patients are quite unstable when we do it. And then the other thing you can do is make some changes to your bypass circuit to conserve blood. Now that works very well, and reducing the amount of priming volume and prime in your circuit does work very, very well. So you can either wrap, which isn't dancing on your head, it's pulling back some blood into the venous system to push out the crystalloid prime, and you can do 400 or 500 mils. In fact, you can do 400 or 500 mils on the arterial side, but the patients tend to get unstable after about 500-600 mils of taking blood off. But that does work well. Then you can go for a low prime and minimum volume bypass circuits, which has been done quite a lot in Europe, but not many centres have done many cases in the UK, although people are trying it more and more. And mini bypass in a meta-analysis of 500 odd patients up to quite recently, lower blood loss, so less bleeding, higher platelet count, but the risk of restenotomy was the same. In other words, if you leave a hole, you've got to go back for bleeding, but no difference in outcomes, no difference in transfusion as yet. So there's just not enough patients to show any differences in transfusion as yet. But as I say, reduced bleeding. And it was the same with all the other trials. You start off with low numbers of patients, you can show reduction in bleeding. You need more patients to show transfusion, and you need lots of patients to show outcome measures. So mini bypass is not there yet because of the amount of patients that have been studied. So favouring mini bypass in terms of, this is the meta-analysis, post-operative blood loss. There's definitely on the left-hand side favouring mini bypass for transfusion. So in summary, cell salvage, targeted use from a purely economic point of view, but if from a sort of every patient saving the blood, then for everybody. Pre-operative donation, not worth the effort and expensive. Hemodilution in theatre, maybe, and as I say, we use it quite effectively. Wrap, little effort, small gain. Mini bypass, maybe, the evidence isn't quite there yet for transfusion. But I would say the whole package of optimising haemoglobins before, during and afterwards is what you need to be going for. Thank you.
Thanks, Andy. That was a very interesting and brisk run-through of those three topics. Can we take one or possibly two questions, as we're a little over time? Thank you.
Hi, Fraser Harman from Birmingham Children's. In terms of the volume of circuit, that's obviously something that is routine for us in terms of babies and small children having small oxygenators and stuff. But what I have noticed where I am now is that our perfusionists cut the circuit right down, and so the bypass machine is banged up against the back of the surgeon, and our actual volume in the circuit is significantly reduced, and we do see much less edema in the babies and small children I think, than in other centres where they use big volume circuits. So I think if it doesn't happen in adults, it probably should do. It's not actually that big a deal, and we certainly see a difference. The other thing I just want to ask you was something in my head I've never quite got my head around, which is that if you transfuse cell salvage blood back that is deficient in platelets and FFP, how come you don't need to give those patients platelets and FFP for bleeding? And your data, again, sort of kind of proved that the patients having cell salvage blood didn't go on to get more platelets and FFP. And so how is the coagulation restored despite that effective dilution or coagulopathy?
It all depends on how much you do. So if you look at, there's studies in the US where they cell salvage all the blood that comes through the suckers during bypass. So that's everything that comes from the vents, the drains, and you cell salvage 10 litres, so the entire blood volume at least 2 or 3 times, you do need to give FFP and platelets. And they had a reduced stroke and myocardial infarction, reduced stroke rate in that, but a massively high transfusion of platelets and FFP rate. So you end up, the basic thing is when you cell save more than 5 litres, the entire blood volume, you then need to start giving products. So in all the studies in that meta-analysis, they've not done very much. They've maybe cell saved a litre and a half, maximum of 2 litres. So it's just in the suckers, it's not the vents, and it's just what comes out of the with your handheld suckers after bypass, and that's maximum a litre and a half. If you cell save that amount, you don't need FFP and platelets. When you go over 5 litres, you do. So it's purely the more you wash out, the less you have. And the answer to the other question is, yeah, I think maybe some perfusionists are not good enough at cutting the amount of the pipes and getting the pump as close as possible because it's uncomfortable, and we don't do it enough. But it has shown to be very effective.
Thanks very much. Can you catch him after?